The Rural Healthcare Provider Transition Project is supported by the Health Resources and Service Administration and the Federal Office of Rural Health Policy. Janine Myers is our RIPT project officer. And then our purpose. So RIPT is designed to help strengthen organizational foundation in the key elements of value-based care, including but not limited to efficiency, quality, patient experience, and safety of care. And our goal is to guide small rural hospitals and certified rural health clinics not currently participating in value-based care through advanced alternative payment models to prepare for and position their organizations to be effective participants in a healthcare system focused on value. And now I'd like to welcome today's speakers. We have Alan Nichols and Ashley Anthony, both from Mainline Health Systems in Arkansas. Alan Nichols has served as the CEO for Mainline Health Systems since 2008. In this time, he's seen Mainline Health grow from 4 clinics in 2 counties in Arkansas to 35 clinics in 9 counties. Additionally, Mainline Health has grown from offering primary and dental care to adding a wide variety of services, including behavioral health, psychiatry, maternal health with obstetrics, care coordination, case management, chronic care management, remote patient monitoring, an HIV program, medication management, the 340B program, as well as services from additional community health workers and dietitians. And Ashley Anthony has served as COO for Mainline Health Systems since 2021. Prior to joining Mainline Health, Anthony served as the CEO for a critical access hospital in Southeast Arkansas. She has a clinical background and has extensive experience in healthcare quality, risk management, and compliance. She has a passion for ensuring all patients in rural communities have access to the highest quality healthcare services possible. Anthony works collaboratively with local, state, and federal partners and has successfully managed multiple HRSA and other grant opportunities to address rural healthcare needs. I will stop sharing now. Thank you both so much for speaking today. We're really excited about what you have to share, and I'm going to hand things off to both of you.
Okay, Alan, I'll let you start us out.
All right. Thank y'all for being here. I'm Alan Nichols, Mainline Health System. We're a federally qualified health center here in Southeast Arkansas. You can go to the next screen. So our mission is to provide the highest quality clinical services to all. 2 important words are there is the highest and all. They really drive everything that we do. We analyze everything we do, and whether we're involved in something depends on how well we think we can do it. If we don't think we can do it adequately, we're really not interested. So when we take on something, it is because we think we can make a difference. And our vision is we want to be a national leader, and we have progress at that. We're recently a gold level. FQHC puts us in the top 10% in the nation. So we're getting there. We're not perfect, but I like to say we have a perfect purpose. We're trying to get there. All right, this is our service area. You can see we're pretty broad in our service area. Really leads to a lot of difficulties management when you're 3 hours from point to point. And that's basically where we are. We butt up to Mississippi. That's the Mississippi River on the right side. And the very bottom of the screen is Louisiana. So we go right up to the border of Louisiana, all the way just outside of Little Rock at our furthest north, and all the way down. We started in the bottom 4 dots you see on that screen, and we have progressively moved north, chasing population, actually. So, and I'll get into more of that detail probably on the next screen or 2. We started in 78. We started in a trailer in a town of Portland. It's now 450 people. We have over 30 locations. I think it's 9 counties, 7 primary locations, 7 counties that we're in primary locations, but we have school-based in and part-time clinics and others. So we're in 7 school districts, multiple clinics in some school districts. We provide medical, dental, behavioral health, psych, women's health services. The other thing that makes us different than some healthcare, not all, but some, is the intensity of services that we provide. So chronic care management, transition care management, remote patient monitoring, diabetes education, pharmacy management, HIV, MAT programs. We also have community health workers, care coordinators, case managers. We really try to, the basic premise is that healthcare is a series of holes. It's gaps in between care. We're just trying to fill in all of those gaps and those holes so nobody falls into those holes. So when we see a problem in the system, we address that issue. Just making sure everybody has access to the same level of care. Today, we're going to discuss the challenges faced in our area. We won't presume any other place. We just know what's going on in our area. I can't believe that it's not similar to other areas. We'll talk about what advantages we believe we have as an FQHC and how those advantages play out in what we're doing in maternal health, and why they make a difference for us. We're going to go over our program, our principles, our goals, where we're at, our current status, what our ideal views are versus the reality that we have, and what we're doing to kind of close that gap.
So for us, we really just wanted to share some of our challenges that we have. And this says in Southeast Arkansas, but it's really not just Southeast Arkansas. It's pretty much the whole state, especially in the rural areas. And I can speak to just the rural hospital struggles. As a hospital administrator, it was very difficult in a rural area in a critical access hospital to maintain a lot of these services, specifically women's health or maternal health. And there are various reasons for that. And so some of these we have listed, but so we have state challenges, and then we have rural hospital challenges as well. So that they kind of compound in size. So our population decline in all of our rural areas, we have a significant population decline that we see, which makes it hard to maintain those services that we do have in the hospitals. And then also, you not only do you have the population decline, you have the population that is still there seeking care in other urban areas, which makes it challenging as well. For the hospitals, we struggle to keep those services locally. Oftentimes, there are multiple factors that play into your decisions to maintain OB services locally, such as physician recruitment is a huge barrier and challenge for hospitals. It's very difficult to recruit any physician to a rural area, let alone a qualified OB physician, either family practice or OBGYN, to those areas. But then it's not just about the physician. It's also difficult to recruit competent, trained staff and for that specialty, including nurses, including surgical services, anesthesia. It really is just the whole realm of healthcare professionals and the challenges to recruit to those areas. Oftentimes you have to utilize other means to get them to come to those rural areas and into those small hospitals, such as, increase in salaries. We see that a lot, that we have to pay a lot more for those providers and those clinicians to come to a rural area to even serve. So that's a barrier. And oftentimes even that doesn't help to get them there. They really need a connection to where you're at, and that's hard. And you want to grow your own. That's also difficult because you really can't. You may have a plan to do that, but oftentimes they get to med school and then they decide they don't really want to do that anymore. So it is definitely recruitment is a huge barrier for these hospitals. The also a huge barrier, which is part of the recruitment as well, but just the call rotation that is required for a physician and or other clinical staff as well. But you don't have redundancy in those staff. So oftentimes you see those small rural hospitals that do have those services, they have one or two physicians, whether they're family practice or specialty, that are rotating and providing care. And that gets exhausting, and the burnout is significantly high because they're always on call 24 hours a day, 7 days a week, at the mercy of being at that hospital to take care of those patients. And even the most dedicated, passionate person will eventually get burned out. And if one of those physicians leaves, you're looking at probably losing both of them, and then you start all over on the recruitment piece. So definitely a difficult issue for hospitals is to maintain those call rotations that are conducive to a somewhat healthy life work balance for these providers. Also, we see in our area that the geography definitely limits our access to care. Our hospitals are, some of these communities are 45 minutes to an hour away from a hospital in general, and even further for obstetric services. So it's definitely very difficult to ensure that there's access for these patients and the care that they need. And a lot of these hospitals, so these patients show up and there's not services available, and then trying to get those patients to an area that can provide adequate care for them. And then another big issue that we face here in Arkansas is that we have the lowest Medicaid reimbursement rate for OB services in the country. So this is a huge barrier because that is the majority of our population is our Medicaid patients. So you find that it's very hard to maintain those services at such a low reimbursement rate. And oftentimes as hospital administrators, you're torn from your moral dilemma of this is the service that your community needs, but how do we maintain the resources and the financial viability of the program? And you find yourself having to make those hard, difficult decisions, whether you can maintain that service or you have to let that service go.
Sorry, I was on mute. Okay, here's some of the advantages that we feel like we brought to this. We're cost-based reimbursed in Arkansas. I know not all states are, but in Arkansas we are, and we have a PPS rate that allows us on Medicaid to actually bill each visit at our PPS rate and not have to completely live off the bundled global fee. So that was a significant revenue difference for us compared to the hospital. And to put a little background in this, the hospital came to us, and I'd say the bravest person in this whole process was the hospital administrator that came to us and said, look, this is losing $2.5 million a year. What is there anything possible? Could it work? And because I would say most hospital administrators, they hang on to it until it collapses instead of looking for something different. But he didn't, and he solved the problem. So, but we're cost-based reimbursed. That's a big financial benefit. We're federal tort deemed. That doesn't completely eliminate our need for coverage, but what we found is it lowers our cost of coverage because federal tort becomes primary and the insurance becomes secondary. So it is cost us less than it costs the hospital. We're National Health Service Corps, big deal, which Ashley talked about recruitment and quality people are what it's all about. And we have one of our OBGYNs, the only reason why we got them was because we're National Health Service Corps. She wanted to work rural, but she had to have her loans repaid. So, I just think that is critical when you're trying to compete against more urban environments where rotations are 1 in 6, 7, 8, 9, 10, and you're trying to compete with 1 in 3 and praying for 1 in 4 if all goes right. We had established relationships with the tertiary care systems in Arkansas. We worked with them on numerous projects, so we were able to have some creative things I'll tell you about a little bit later that allow people to get care locally, where before they were just getting referred out, and if they went, they went, and if they didn't, they didn't. We have a holistic model of care. We take care of wherever that patient is at. And so we're in their homes, we're doing home visits. We have case managers on the phone. We do after hours. We're trying to touch those patients no matter whether it's maternal health or primary care or whatever. We're trying to touch that patient numerous times between when they see a provider. Because that's just we found that's not enough to move numbers, just having visits. It's all the ancillary services we provide and the extra care that we provide that end up moving our numbers. And it has worked. We're consistently recognized by HRSA. We're recently a gold level FQHC. It's really hard to do it consistently over time. It's very hard to continue to improve on improvement. But we've got a great team that's committed to putting in the effort to do that and making sure that our numbers are improving. They're in front of every person every day. Everybody's incentivized to do so. We have incentive programs for everybody in this organization that are tied to these outcomes. And so everybody is literally bought in. And we also have the Arkansas Rural Health Partnership that's been critical in building our relationship. This is a group of hospitals. Initially, it was hospitals in Southeast Arkansas, and now it's expanded outside of Southeast Arkansas. It now includes 2 FQHCs. We meet on a monthly basis, and we do things that are mutually beneficial, and that has been critical to building relationships where there's trust. And I would say that's probably the biggest hurdle that we found is trust. There's a lot not known about FQHCs, and there's a lot of distrust between hospitals, and I'm just talking about our area, hospitals and FQHCs, and there's a lot of jealousy in some of these benefits that you see on this screen. Our partners have spent too much time saying that's not fair and you shouldn't get that, and why do you get this, instead of looking at it and say, well, how can I leverage this to benefit my community and my organization? And I'll give Scott at Drew, I'll give him credit. He said, I'm not fighting this. How can I use this? And by doing so, I think we put in a program that's greatly benefiting our region and our local hospital. But it all kind of stemmed from this relationships that were built through this rural health partnership. And I'll get into this model and I'll tell you, this is our dream. This is what we want it to be. And we'll talk about where it's at and then what we're doing to kind of close the gap. But when we looked at getting involved in this, we had no interest in doing things the way they were done because they weren't working. When you're last in the nation in outcomes, which we are, there's no need to try to just perpetuate a broken program. And what we saw is the big limiting factor in all this was weekend call. Of course, money is a big deal, and we'll talk about that. But one of the huge thing that got it that is impeding moving forward in maternal health was the weekend call, and it was when you couple that with being the lowest reimbursed in the nation. Where we got to is these hospitals were having to produce 200, they were having to deliver 225 babies to cash flow per provider, per OBGYN. Well, the national average is 140 to 180. So you had to deliver 225 to break even. So we're in these declining population areas, small communities. I mean, the towns around us are, you have just to the west of us, a town of 5,000, just to the east of us, towns of 2,500 and 5,000. And so these are not big communities that have hospitals trying to hold on to OB. And those low numbers don't create enough babies to sustain a viable program because you need at least 3. So if you need at least 3 and they're having to produce 225 each, well, they're not delivering that many babies in the county. And that comes to another thing that overall in hospital health or lack of health in these hospital systems is with these population declines, the circle of viability for them is having to get bigger and bigger and bigger. So used to a county hospital could survive on the patients from that county. Anymore, they're having to survive on the patients from that county and each county touching them. More and more, bigger and bigger circles. And frankly, with OB, they just cannot deliver enough babies to be viable by themselves, standing on their own. So what we said was, can we build a more regional hub and spoke method? And the idea behind this is that, wouldn't it be great if we could regionally in our community of Monticello in Baptist Health Drew County, if we could deliver babies 7 days a week in this larger hospital, and these critical access hospitals that are around us, we would have different levels of access at them. Some of them we could deliver babies Monday through Friday, but that doctor in that community could be on weekend call rotation at this centralized regional facility, 15 miles away, 25 miles away. So it's in some cases 40 miles away, but it's not tremendously far, like going to Little Rock and being 2 hours. And then others, we could have prenatal care, and we could also have women's health nurse practitioners going into communities doing prenatal care, but have this blend where we work together and solve the one biggest problem, which is the weekend call rotation. And I'll tell you, the reality of this is that when you talk about this, everyone you talk about says, yeah, that's a great idea, but I want to be the regional hub. That became the catch point to all this, is that the hospital administrators could believe in this. They could say it's logical, but we don't want to give up anything. And so what we saw as we tried to put this together is actually several of these dots on this screen, if they were actual communities, and you saw that actually lost their maternal health care completely in the process of us doing this and trying to execute this, because they did not want to give up anything, so they ended up giving up everything. And so now we're providing care in those communities, and you know, and we're having to do so without local delivery, and that's unfortunate, because I think you could have kept local delivery if you would have looked at it from a regional perspective. Is it as ideal? It's not near as ideal. Go back 1 second. It's not nearly as ideal as a completely local program standing on its own. That is the closest you can get that delivery point, and the closest you can get that care, the better it is. But in lieu of losing it completely, we believe a model like this could stand for years, because you solve the weekend call rotation. And one more point about a difference in us, because of PPS, we can cash flow at 200 deliveries a year versus the hospital's 225. That is a big deal. That difference is the difference in losing money and breaking even. We wanted all regional hospitals and clinics to be involved. We want everybody involved. We're slowly getting there. There's still some distrust even after the outcomes, but we're also having new systems around us reach out and say, hey, can you look at our program and could you take it over? Large systems. We wanted tertiary hospitals involved. We've been very fortunate with that. We actually have 2 that are getting involved, and we'll tell you a little bit how they're getting involved later. It's primarily due to high risk pregnancy, and we wanted a 1 in 6 rotation. That would take all the pressure off. We're at 1 in 3. We believe if we can coordinate with more of these surrounding hospitals, we can get to the 1 in 6. 1 in 3 sustainable. 1 in 2 is a death sentence. It's going to die. But once you go above 1 in 3, the further you go, the more sustainable it is. We wanted to have a positive cash flow. We're not in this for money. We don't do things to make a bunch of money, but if we don't have money, we don't have volunteers. Those doctors aren't volunteers. They have to be paid. And it costs more to deliver care here than it does in Central Arkansas. You just have to pay more for that 1 in 3 rotation than you do for 1 in 6 plus. We wanted prenatal care close to the patients. We're working on several different programs. Actually, UMS has a new program training primary care doctors to do prenatal care. We're very much in favor of that. We're going to enter those training programs for all of our physicians across all of our area this year. But we also brought nurse practitioners, women's health nurse practitioners, to areas that hadn't had prenatal care at all in years. And that is progressing. It's a slow process, but it is progressing. We wanted weekday and night deliveries. We wanted deliveries at more than one hospital, and we wanted weekend deliveries at a centralized hospital. We're not doing great at that. We're at one hospital right now, and the other hospitals resisted this to the point that they had to close their whole program. So that's very unfortunate. There are a couple hospitals in our region that are still delivering. And we hope we can work together to stabilize their programs, because this is the thing. We do not want to take over the world. I've heard that said about FQHCs. We have no desire to take over the world, but we do want to change it. We're trying to change how things are done. We never had a desire to, we never woke up at a planning meeting and said, we want to do women's health and deliver babies. That never happened. We just reacted to a need in the community. And we want to improve outcomes. We're not going to do this without getting better. You're last in the country. If your primary focus is not getting better and having better outcomes, then you shouldn't be in this business. I mean, our outcomes are abysmal. But we're doing things to make a difference and to move that needle. I just wish we could get the results and the outcomes much faster than 2 or 3 years takes you to get the numbers. But anyway, those are our goals.
So for us as an organization who is very quality outcome driven, it's very disheartening to know that our state is the last in the nation as far, or I guess you can say we're first in the nation, but it's not for a good reason. We're the first for the worst outcomes. As Alan says, you have to be worst to be first. But that did give us some incentive to make a difference and to see that change. So our goals that we have set for our program is that we really want to see that early entry into prenatal care for our patients, getting them in that first trimester to get that care initiated. We also want to see the C-section rates lower in our service area. So that's a huge problem. And we are continuing to study that data to see how those trends are actually occurring. Are they occurring with those patients that are delivering locally, or are they delivering at a tertiary facility that they're having to drive and plan those deliveries, which could lead to a C-section? So that's something that we want to know more about, but we do ultimately want to have the goal to lower our C-section rates, which will help our patient outcomes. We want to, of course, increase breastfeeding and encourage it with our mothers. As we all know, that's best for the baby. And we want to decrease that maternal infant mortality rate. So that's the big one. We really want to make those numbers, we want to see those numbers change in a more positive direction. Especially knowing that the majority of those deaths are preventable. We also want to decrease the number of mothers that deliver in the ER. So we want to see them making it to their facilities that they need to be at to deliver the care that they need for mom and baby. We also are working on the hypertension, maternal hypertension, which is a huge issue in our area. We have a huge population of high risk patients with obesity and hypertension being two of our biggest areas of focus. So these were our quality goals that we are working on. And so if we meet these goals, which we are very, very driven organization, and so we will meet these goals. And so if we meet these goals, ultimately we will see the impact to the overall numbers for our state. So a little bit about our program. So Alan touched on how we kind of got here as far as the hospital reaching out. And so we wanted to be a partner, and we wanted to be help answer this problem. And so we were fortunate enough to find a grant opportunity that we did apply for that would help us get our vision up off the ground and help us to build this program. So we did receive that grant, and we are in our second year of the grant. And with that, we were able to bring on 2 OBGYNs into our program. And that was in August of 22. And so one of them was already established in the community, and the other one is from a local community that when she graduated, she wanted to come back to. So we were fortunate in that respect. And so we had our physicians, we were able to recruit some mid-level women's health nurse practitioners to come in and be a part of our program as well. And we started setting up this model of care that we have on the map there. And we started reaching out to these local hospitals that maybe don't have obstetric services at their facility. They used to, or they don't anymore. And so, but we wanted to bring the care to those patients in their community, so they are not driving 45 miles to the nearest facility to get care. So we're partnering with those hospitals, and we are able to provide services and OB care throughout the pregnancy at those facilities with the women's health nurse practitioner who works directly with their physician to coordinate that care and make sure those patients are getting taken care of. And that helps increase the or decrease the no-show rates to appointments, and that we're seeing that being beneficial to them. We average about 40 to 45 babies a month currently in year 2. Which is really good. That's a lot of babies. So this year, actually this month, we've added a family practice OB physician to our group who actually was a physician at a local hospital, and one of those hospitals that unfortunately had to close their OB program. So she made the move to join with us, and so she can continue to deliver those services in that area. We provide, one of the things that we knew we wanted was we really wanted to make sure that we provided intensive maternal health case management to our patients. So with us providing chronic care management services and working how we do in our medical side, in our primary care world, we've seen the benefit of having that person that works directly with you and is providing that education and that constant support, and it just makes such a big difference on the overall health of that patient. So we wanted to incorporate that, and we felt that it needed to be intensive. So it didn't need to be once a month. It needed to be weekly. We need to be touching those patients continuously throughout the pregnancy and during the postpartum time. So we were able to provide those services. And then we also incorporated a maternal health, behavioral health therapist into our program. And our therapist is only there to serve preconception, during the pregnancy and postpartum patients. That is her role. And she works directly with those physicians and mid-level providers to coordinate that care, which we've seen to be very beneficial. This was new for us and for the area, to have a specialized therapist that was specific for these mothers, but we found it to be very beneficial. We also incorporated community health workers that specialize in maternal care into our program. And so this is also a wonderful program that really goes out and meets the patients where they are. So they go out into the homes and they meet with them and they assess them and assess their social determinants of health, and are able to assist them to get the things that they're needing. So that has been a blessing, and those patients are very engaged with their community health workers. They relate to them. They look like them. They work with them. They call them when they need something. So they're work very closely with them. And so those 3 positions, the case manager, the behavioral health therapist, and the community health workers, work so closely together on a daily basis. And then they coordinate it with the other clinicians to ensure our patients are taken care of. We also have dietitians at Mainline, and so we're able to incorporate nutrition for these moms and for the babies, and provide those services to them as well, so that we can continue to educate them and hopefully make some improvements and help them to understand the importance of a healthy diet. a big task, but we do have that service that we were able to incorporate. We're not there yet, but we're getting there. But with the remote patient monitoring, we want to be able to monitor those patients at home. So they're not having to come in continuously. So we're actually working on that currently to get that up and running. But that way we can monitor their blood pressure if they have hypertension instead of having them drive into the clinic to do blood pressure checks every day or every other day. So we're able to incorporate the diabetes monitoring and the hypertension and even weight from a remote setting. So that will be beneficial to our patients. And then for those patients that need it, we're able to provide home visits to them. So our nurse practitioner goes out into the home and makes those visits. We're also incorporating that with our postpartum patients because since we've implemented our program, one of the things that we've found is that it's difficult to get the patients back in after delivery to see for follow-up appointments. They may take their baby for child checks, but they're not checking on themselves. So that's a big risk factor that we've identified. And so our nurse practitioner is able to go into the home and provide those postpartum visits as well, and follow-up care after delivery to ensure that they're getting the things that they need and are healthy. And then we are working on our program for education for our patients. We started out with just our own internal book of what our patients can anticipate with our program. So we explained to them the services that they're going to be getting, how often they're going to be communicating with us. And then there is information in there too, just around like what to expect during your pregnancy and in those different stages of pregnancy, and how your physician and your medical team is going to work with you. But we're looking to expand that to incorporate classes for these patients within the community, and utilizing the hospital or other resources in the community that we can work with to coordinate those classes, and then even provide ongoing individual education for the patients as well. And then, as Alan talked about, the tertiary facilities, but we have telemedicine for high-risk OB patients. And so our goal with this is that if you have a high-risk patient that is being referred to a tertiary facility for delivery because they're too high risk to deliver in a rural area and they need a higher level of care, we oftentimes find that those patients don't make it to those facilities for prenatal care. So we wanted to find a way that we could work with those facilities and provide the prenatal care at close to home for our patients, all the while educating them and helping them to understand the importance of making sure they deliver at that other facility. So we're working with those facilities to have the appropriate equipment so that we can do the ultrasounds that are needed and provide the services. And we have a direct line with those high-risk providers so that we can coordinate that care for those patients. So that is our program, and that's where we're at currently. And every day we are building and we're growing and we are learning as we go. And we are just adapting and working with our partners every day to coordinate the care and ultimately improve the outcomes for these moms and babies.
The main premise behind all this is that the viability of delivery in these small hospitals is really strained in the state of Arkansas by the reimbursement rate. So basically, you can figure, I beat the drum all the time, is they can figure out how many hospitals can be viable just by doing the math on the deliveries and what it's reimbursed. And currently, there's not a lot of interest to change reimbursement in Arkansas, so that it really puts a strain on them and gives them an impossible task. I would say that I don't know a single hospital in Arkansas that cash flows an OB program. Not one. And your small hospitals are losing 1 million, 2 million, larger hospitals more than 2 million. So this wasn't an area we looked to be involved in. It just is an area of need that came to us. And just another little point about how we react to the community is that we moved into Monticello in 2010. And at that time, they had lost a primary care provider, a couple of them. And their wait times were like 3 hours with an appointment. When you checked in, actually you got out 3 and 4 hours. And so there was a huge primary care need, so we moved in and built a big building and started seeing tons of patients. And since that time, there's been 2 more doctors moving down and open up a clinic, and multiple nurse practitioners hired to work in multiple clinics. And so the primary care atmosphere changed tremendously over that time. So at the same time, the OB and maternal health was collapsing. So we pivoted and we reduced our footprint in primary care because that's what the community needed. They didn't need as much of our primary care as they had previously. And then the need was more in the maternal health. So we try to be responsive to whatever the community needs. And once again, emphasize we're not here to take over the world. We just want to change it. And so that really is part of the background of why we're doing what we're doing.
Thank you both. That was really great information, very relevant information. So thank you for the presentation. I know we have a question in the chat and we wanted to open it up for any other questions. It looks like Brittany asked, have you considered utilizing locum tenens positions to help with recruiting to your rural facilities?
You know, I think that it is definitely an option, but it's just, you have to understand just how thin the margins are here. And locums the cost factor to locums gets to be really, really significant. And even like recruiting for the weekend, a laborist, the cost is so outrageous that I tell people all the time is that maternal health in an FQHC done perfectly breaks even. Now, your hospitals around us would say, well, that's great because we can't come close to breaking even. But you really can't make many mistakes in Arkansas with our reimbursement. You have to really think about every penny you spend in order to get it to break even. And we're not willing to give up all these activities that we do that we believe make a difference. We're not going to give up community health workers. We're not going to give up case managers. And one thing about the case managers and the community health workers, we follow that baby through year 2, even if they're not ours. So when they're referred from another provider and another group, we continue to follow them through year 2 of that baby and get them back to care with their PCP and get them to have those well child visits and get their immunizations. And we're funneling them back to and we're not willing to give up all those uncompensated activities because we believe those are the ones that are actually making the difference in the outcomes, because those are the ones that are getting the patient into care, showing up to their visits and delivering at the right facility at the right time, instead of just no prenatal care and showing up to the ER.
And we have another question in the chat. Feel free to come off mute if you have other questions. This is how do you reimburse the nurse practitioner / provider for travel equipment used per visit, or a flat rate, your vehicle or personal?
We pay mileage for their vehicle and we pay salaries to our providers, so. They're a salary provider with all benefits and they get paid the federal rate for mileage. I tell you what, of all the nurse practitioners we have, those are the ones that would probably do it without even being compensated for their mileage. They just love what they do. Well, if anyone ever has any questions, I mean, I don't know if you could share my email address or whatever. I guess I could type it in here. Just give us a buzz and we'd love to talk to you. There's my email. Send me the questions and as they come up, and we'll tell you what we're doing, because we can't tell you what you should do, because we don't know your situation, but we can tell you how it works here.
Yeah, and we would gladly share your information too in our follow-up or when the recording is available. Well, if there are no other questions, or feel free to keep putting them in the chat for those that are still on. We do have a couple of post-poll questions if you would provide your answers there. So a couple of those repeating questions you answered earlier. And then we also have 2 additional ones, just overall satisfaction. Thank you, Alan and Ashley, for presenting. This was really great information. I know a topic I was really interested in hearing about. It was an honor to have you both. Then for attendees, just complete a evaluation if you're interested in that credit. Let us know if you have any questions in the meantime, or want to get in touch with the presenters. And thank you again.